Hello, my name is Cathy Streutker. I've been asked to give a talk today on Barrett's pathology, low-grade, high-grade, and indeterminate or indefinite dysplasia, and the controversies that we still experience in making a diagnosis in pathology. I have no disclosures for this talk. This is a typical biopsy that we often see in Barrett's pathology, where we see a case where we see gastric-type epithelium with intestinal metaplasia. You can see goblet cells scattered around throughout. We also see that there is some nuclear hyperchromasia where the nuclei look darker and are coming up off the base, so they're stratifying a little bit and they're hyperchromatic. There's a little bit of gland crowding, especially over here. And when we look at surface maturation, where we want it to look more like gastric epithelium as it comes towards the surface, in some areas it looks quite good. And in other areas, we see that there is stratification and abnormal dark nuclei coming quite far onto the surface. So there isn't perfect maturation. And this is all occurring in a background of inflammatory changes in the lamina propria, where we see a number of lymphocytes and plasma cells. So cases like this are a real conundrum because there are some features of dysplasia here, but there are also are features where we would be thinking about benign or reactive changes, considering the background inflammation in particular. So it leaves us with, do we call this low-grade dysplasia, reactive, or just put it in the middle and call it indefinite for dysplasia? According to the Vienna Classification, this is the pathway of changes that we look at when we're diagnosing normal versus indefinite versus low grade, high grade, and then intramucosal and invasive adenocarcinoma. And the Vienna Classification was an attempt to try to get all pathologists to call the same things in the same way, using the same language so that they could be more comparable and easier for clinical groups to understand. However, we know that there is a persistent problem with interobserver variability at all levels of these diagnoses. This means that if two different people look at the same case, they may not agree. And in all honesty, there's considerable intra-observer variability in these cases as well. So if you show me the same case at a different time point, maybe several days down the road, where I might well have started off calling it low grade, I might change it to indefinite or consider it just to be reactive. So we are not good at distinguishing reactive changes from dysplasia and dysplasia from malignancy. And while the most marked variability is for low grade and indefinite, really, the changes are across all the spectrum, so that even high grade can be mistaken for negative and negative can be mistaken for high grade. It's not that surprising that the variability is the greatest for low grade dysplasia. We know that a lot of the genes that are turned on to survive reactive changes are the same genes that help with survival and proliferation. They're the similar genes that will be turned on in dysplastic things. So it's not that surprising that the nuclear features are similar between the two areas. This is a nice review that was done in 2019, where it summarizes the major histopathologic features that we look at to make the different diagnoses. And one thing to point out here is that these are really subjective, so that there's no one who can actually say what exactly is an enlarged nucleus, hyperchromatic nucleus, what is atypia when we're looking at that. There is no defined criteria that says this is a reactive level of atypia and this is dysplastic atypia. So we're already acting on a spectrum of what we personally think these changes are. So again, this correlates with the not surprising fact that if it's really normal, we agree reasonably well. And remember that kappa values of 1 mean perfect agreement, and when you get down by 0, it's more or less agreement by chance. So the higher the number, the better the agreement is. So for normal, we're actually fairly good. For high grade and adenocarcinoma, we're in the fair to quite good range. But when you're looking at indefinite for dysplasia and low-grade dysplasia, the kappa values are, in a lot of studies, when you're down around 0.1, little better than chance, which is not comforting when you're trying to explain this to patients and clinicians about why things keep changing. So is there any way that we can make the pathologic diagnosis more useful or at least more reliable? And there have been several studies now that show that the predictive value of low-grade dysplasia was definitely increased in cases where you had at least 2 people agreeing on the diagnosis. This is usually considered to be 2 expert GI pathologists, but sometimes is 1 generalist and 1 GI pathologist, which would be the most common situation when you have a diagnosis made in perhaps a peripheral center and sent in for review to an expert GI pathologist. And because of these studies, this expert review is now recommended by some international guidelines, because it basically means that in patients with low-grade dysplasia confirmed by this method, they're much more likely to progress to high-grade dysplasia and to outright malignancy, which kind of is a backwards way of confirming that it actually was low-grade dysplasia in the first place. So these studies with expert GI review are predominantly performed in tertiary centers using what are called expert GI or Barrett's pathologists. In these studies, one of the things that they particularly note is that dysplasia is usually overdiagnosed, and review by an expert GI pathologist will downgrade a significant number of cases, most often low grade, to either just negative or reactive changes. But one of the major questions this raises is, what exactly is an expert GI or Barrett's pathologist? Is this someone who has done a fellowship in GI pathology, which may or may not involve looking at a significant number of Barrett's cases, depending on where the person did their fellowship? Is it somebody who just sees a lot of cases or has years of experience and therefore just has a good visual eye for what they're looking at? This isn't really defined, and right now an expert GI pathologist is just probably whoever you tend to send your GI consults to. But now some recent publications are trying to define what exactly an expert reviewer status is by trying to create a group that agrees with each other, so that there's diagnostic concordance with the group. And the group that's done the most work on this is the Dutch Barrett's esophagus group, where they developed a training program using 80 cases defined as indefinite and low grade, defined by several of the pathologists within the group, by the way, but then went through several rounds of review and group discussions to reach consensus between the 14 pathologists who are now considered at that point in time to be homogeneous in their diagnosis. Sadly, one pathologist who was felt to persistently underdiagnose dysplasia was excluded from the group and sent to the back room. This group then formed their Barrett's pathology review panel, which I believe acts either for a large region of Holland or for all of Holland. And one issue that I think could be a problem for them, and I haven't seen follow-up data from them, is that just because you agree on diagnoses at one point in time, people tend to drift, and so it's entirely possible that over time they would no longer have total consensus. But I would imagine that if they've done all this work, what they should keep doing is reviewing cases within the group to make sure that they maintain their consensus diagnostic abilities. They also went on to form an international group where they're still working on using the same principle to reach consensus, to try to get an international group that will be able to serve as an expert referral center. And interestingly, in the study that they've done on this, they looked at things that improved interobserver variability within the group and things that did not improve interobserver variability. And it's maybe kind of self-evident, but self-identification as an expert does not necessarily mean that you are good at reaching consensus with the group. What is perhaps a little more surprising is that the number of Barrett's cases seen in practice actually did not improve variability between the different pathologists, which I personally was surprised by, because I would have thought that the more you see, the better you get. And in some ways, this kind of contradicts the things that did improve variability, which is particularly increasing years of experience, where again, you might be expected to have seen more cases, and also working in a teaching hospital, again, most often a teaching center where you're seeing increased numbers of cases and perhaps more difficult cases. So this is something that we may well see increasing in the future, because this will give us groups where people at least are in the same ballpark, even if they aren't perfectly agreeing at all times. Other approaches are attempts to create a specific reporting scheme in how we evaluate cases. And this study looked at 20 different morphologic features. In all honesty, we do use most of these either consciously or subconsciously to make a diagnosis of dysplasia or not dysplasia. But the idea of trying to go through 20 different things for each separate set of biopsies and score these and add it all up and try to come to a number and make a decision based on that number is not totally practical in the greater scheme of trying to get cases signed out in a decent timeline. Other studies pulled 4 of these major criteria, particularly involving the nuclear features and the surface maturation, to also try to help standardize. And this may be something where, even if we aren't using the specific numbers, it at least tells us what are the most important features that help us decide whether or not something is dysplastic. Another approach by Liz Montgomery's group is looking at the epithelium in a completely different way. And her group looked at the lines that you see in normal gastric foveolar type epithelium, where you see a little line of mucin bubbles across the top, then the line at the bottom of the bubbles, then the cytoplasm line, and then the line of the nuclei at the bottom to create these 4 lines. And if these are there, if they're all 4 there, then she felt that these were all benign or reactive. But if they start getting jumbled up and lost, where here you in some areas have all 4 and in some areas you kind of wonder, then you start thinking about indefinite or dysplastic. And their group felt that if you could find cases with absence of these 4 lines, it helped to identify cases with higher risk of progression. So again, does it help with the actual diagnosis? Maybe, maybe not, but at least it identifies cases that are higher risk for progression, which is clinically useful. Another approach is to look at biomarkers, and unfortunately, Barrett's dysplasia and Barrett's adenocarcinoma are among the most highly molecularly variable of all cancers in the human body. There's a huge variety of mutations that occur, so there's no single biomarker that accurately segregates benign from dysplastic or dysplastic from malignant Barrett's esophagus. There are molecular studies using panels, which can help predict those that have risk of progression. But these are quite expensive and have not yet made it into clinical use. And this is Rebecca Fitzgerald's group, which has done a lot of work in this area. One of the markers that is used most often is P53, and this is a tumor suppressor gene involved in the cell cycle. And in benign epithelium, you can see it's expressed at a normal low level, not terribly strong and not in every cell. And if the protein is mutated, it will either get retained longer in the cell but not actually function normally, in this case, where it's abnormally strong, or you get a no mutation where it's lost and it's completely absent. One study was using this, or several studies have tried to use this to improve interobserver variability, and they have found improvements, but the improvements in kappa are still relatively small. But it still may be useful because abnormal P53 in these cases by itself may predict progression to high grade or to adenocarcinoma. So this is one biomarker that I use occasionally. I don't use it on every case, but considering that it may predict progression, this is something that may come into greater clinical use, as we may be using it to define people who need greater follow-up. Future approaches could be AI. So if you're looking at artificial intelligence, you need scan slides, and a lot of the slides using group consensus have used a lot of scan slides in order to show the cases between people in different countries. It's much easier. So this creates a group of cases where people agree on what things are that could be analyzed by AI or neural networks to try to differentiate dysplasia from no dysplasia. And this is a small study where they did think that they had reasonable results separating them. AI definitely relies on pathologist slide annotations to learn. So pathologists actually have to mark each slide in exact areas on the slide to tell the system where to look. And here's dysplasia, and here's malignancy. So we have to assume that the annotations are correct in order to trust the results. And if we cannot necessarily agree on what the cases are between ourselves, that makes this very difficult. It will need larger studies. It will need some of these consensus groups to use their slides for these studies to try to see if we can get this to work. So I think that is something that we will hopefully be able to use in the future, but we do not have any reliable usage in clinical practice yet. Now, just to talk briefly about high-grade dysplasia, this is a case where an outside diagnosis called it high-grade dysplasia. And then when we get the EMR specimen in our center, we see these complex anastomosing glands running sideways through the lamina propria. We have atypia, we've got some debris in the glands. And so this one was diagnosed as intramucosal adenocarcinoma. So is this really a discrepancy across 2 separate specimens? Depends on your definition. High-grade dysplasia, as I mentioned before, has lower but not zero interobserver variability. And unfortunately, we can still mistake benign or low-grade changes for high-grade, and high-grade changes can be mistakenly called benign. It doesn't happen often, but it is still possible. Intramucosal adenocarcinoma by itself can be underdiagnosed, especially in biopsies. I particularly am very cautious unless the changes are very dramatic. This is also an area where we have an East versus West diagnosis issue. What pathologists in the so-called West, which is basically North America and Europe, call high-grade dysplasia is often called intramucosal adenocarcinoma by pathologists coming from Southeast Asia, where they've seen a lot of this, not so much in Barrett's esophagus, but it's coming across from this gastric cancer diagnoses. So this is something that the Vienna Classification was intended to try to fix, but has not completely eliminated. When we're trying to decide, is it just high grade or is it intramucosal adenocarcinoma, we do try to look for some specific features such as dilated tubules with debris, single cells in the stroma, and cribriform growth. We don't often see desmoplasia in these very superficial cancers, so that doesn't help. So there are things that can guide us, but it is still an area where there's a lot of crossover back and forth between high-grade dysplasia and intramucosal adenocarcinomas. Once we get the endoscopic mucosal resections, we tend to have better agreement, which is probably just because there's more mucosa and more dysplasia or adenocarcinoma present, which makes life easier. That said, EMR pathology is often changing the diagnosis from the pre-EMR pathology biopsies. In this study, it was a 10% upgrade and a 20% downgrade. So you have to expect that the biopsy diagnosis may not agree with the EMR diagnosis. So in conclusion, interobserver variability and frankly intra-observer variability continues to be a challenge for Barrett's dysplasia diagnosis. We don't have perfect fixes for any of these problems. We do feel that consensus agreement on low-grade dysplasia between at least two pathologists, where at least one should be whatever you want to call a GI expert, Barrett's expert pathologist, helps predict who is going to progress to high-grade dysplasia and intramucosal adenocarcinoma. Benign and reactive and high-grade and intramucosal carcinoma cases have less interobserver variability, but it does still exist. Biomarkers and molecular testing and analysis by AI offer some intriguing possibilities, but nothing is currently in use. Thank you for listening to my presentation, and I hope this was helpful.